Welcome, everybody. It's Nigel Giam, the lead GP training program director for the St Mary's Scheme and course director for Mentor MRCGP. I'm so happy to have Tom join us today. So, Tom, well done. Fantastic
Thank you.
score on your recent SCA. And I thought we'd just break it down to the audience a little bit as to some of your game changers, but just introduce yourself a little bit, where you are in terms of your training and how's it all going.
So yeah, my name's Tom. I'm a with GPST3 in the Maidstone Tunbridge Wells area. I had well basically I've been on extension because I did my SCA kind of due to lots of circumstances at the last kind of possible opportunity, hoping that I would have passed it first time just in time for to finish when I was due to. And I'd had a bit of an extension anyway because of paternity leave, extended paternity leave. So I was due to finish a bit late, and then plan had been to finish in December. That
Yes.
didn't happen, so we're now in sort of April time. I did it in March, and yeah, so now just waiting to CCT. I've got
Brilliant.
basically a month to go. Got the ARCP in a couple of days, and
Yeah.
final run ahead.
Exactly, exciting times, and so happy actually that you passed. So you came to the masterclass as an observer. We had a couple of
Yeah.
pretty intensive one-to-one
Mm.
sessions, and your mark, I mean, just increased by a huge amount, over 30 marks compared to your first sitting. So you were quite close on your first sitting, but you went on to kind of really smash it in the high 90s, which is
Yeah.
the realms of the top scorers. What do you think your game changers were for the three domains? So if we start maybe with data gathering, what did you learn from the course? What did you think you did differently?
So, well, I guess the data gathering. I mean, the thing that the thing that I'm not saying this because this is your video, Nigel, but it really did. You introduced it to me. The particularly getting the ice early on because
Yeah.
for me, I'd sort of been preparing with a lot of old CSA books, so
That's
the
right.
previous course and
Yeah, yeah,
the previous type of exam, and I had noticed that they were sort of organized by, cardiovascular gynecology and things like that. And so it'd be a case of, asking all the key red flags and
mm,
stay together. And then usually right at the end, they would have a thing like in the mark scheme of elicits ice.
yeah,
And for me, that was something you tick off at minute 5.
yeah,
And for me, what you introduced actually, that it wasn't a final tick box. It was a core of the this exam. And actually,
absolutely.
I think before I'd sort of thought of ice as this kind of annoying irritation where if if a patient had a sort of
Yeah,
like psychosocial circumstance
yeah,
which was at odds with my gold standard
yeah,
management, I would sort of get annoyed because it would
yeah,
be nearly the halfway mark
yeah,
and
yeah,
think
yeah,
maybe I can ignore it.
yeah,
Maybe I can change their mind.
yeah,
Maybe they wouldn't notice it in the mark scheme. And I think that was a real way, one big way that I my marks really dropped.
yeah,
And so what you really introduced to me was actually you elicit this really early on, and particularly in terms of the result stations as well.
yes,
And you've got really useful technique of asking them, say about for the first minute or so, giving a very brief catch up of why
yeah,
results were taken, and actually just eliciting data,
getting, yeah,
uh, giving the diagnosis and eliciting ice, and then maybe going into what the initial symptoms were. And
yeah,
and again, I'd got that completely the wrong way
yeah.
round.
Yeah, I think that's really interesting because there's so many mixed messages out there as to,
Yeah,
especially that in the follow-ups. Actually, I was doing just a one-to-one today where someone just spent literally 6 minutes just retaking a history all over
yeah,
again, and it's
yeah,
it's not really what the exam's testing you on. It's testing you on where you are in terms of the patient's narrative,
yeah,
and specifically as you've mentioned, and because it's a standardized exam, all of these patients are going to have ice built into their role
yeah,
playing. So it's fundamental to get it out early. And
yeah.
if a patient's coming in literally going, I'm expecting to get the results, well, then give the results
Yes,
basically, in
exactly.
context. So that's
Um,
really important messages for data gathering. If we move to clinical management, what sort of game changers did you have there, do you think?
so the clinical management. Well, I think one thing I did remember would actually, just keeping in mind the mark scheme firstly, actually, because I think, and this is during the exam, remember that it's easy to remember that you might if you forget something, or it's easy to think that you might have failed the case because you
Yeah.
forgot to request a
Yeah.
particular test in. And yeah, it might be relevant, but actually, um, forgetting one aspect of the clinical management doesn't mean you fail the station. It might
Correct.
mean you
Yeah.
drop a couple of marks.
Mm.
But actually, the first thing I always wanted to remember was actually for a clear pass in clinical management, you get 4.5 marks. A pass, you get three. Even a fail, you only get 1.5. You get still 1.5. So
Mm.
actually, don't get too worried if you later down the line, if you forget something.
Yeah.
And that was probably the one big thing that I did remember. And then clinical management, give the diagnosis by minute six.
Mm.
Don't let that overrun.
Mm.
And so and this is something that I think we had a little joke about because I was so dogmatic about it
Mm.
in all my things. Give the diagnosis or your thoughts at minute
Yeah.
six, relate it to their ICE
Yeah.
or psychosocial situation,
Yeah.
and then usually there'll be some sort of dilemma there.
Yeah.
And if you and that and to be honest, I was quite formulaic with that. So
Yeah.
work out what is going on, whether that's a
Yeah.
diagnosis or some other
Yeah.
key to the station,
Yeah.
relate it to their social circumstances
Yeah.
or their ICE, and then explain the dilemma,
Yeah.
and then do that within a minute, and then you've basically set up the next 5 minutes. It's
Yeah.
a good
Yeah.
back and forth.
Yeah.
The patient knows exactly what's going on. The
Yeah.
examiner knows exactly what's going on, and that might even be. And I had one of these cases in my exam. That might even be that you don't know exactly what is going on, and there are cases that are designed like that, where
Yeah.
they're designed to be vague. And I
Yeah.
had one, and I had one of these in my exam. It was a, don't worry, I'm not going to give away
Yeah.
the secret of it, but it was a very vague presentation, bit of a strange sort of social
Yeah.
situation.
Yeah.
And by minute six, I'd ruled out all the red flags, done. And I said to him, look, I think I think what is going on might be related to this
Mm.
change in social
Mm.
circumstance, but
Exactly.
I can't actually work out if I'm being, if I
Mm.
can't, I don't know for sure actually at the
Yeah.
moment. And then I went back to, I've ruled out these red
Mm.
flags. What we could do is a couple of extra tests
Yeah.
that we hadn't done, maybe a symptom diary, just
Yeah.
going back to the basics. And I went away thinking, oh, gosh, I'd done it. I
Yeah.
was a disaster, and I'd done really well in it. And clearly, it was a case designed like that. So I would say, don't worry if you are floundering a little
Yeah.
bit, but just don't pretend like you do know. Just be honest.
Exactly. Because there's cases that are there really to test uncertainty. We already
Mm,
know there'll be cases where there's no clear diagnosis.
yeah.
And actually what we're trying to look at really is, as you said, serious or not serious. And if it's not
Mm,
serious, then it's about risk containment. It's about going back to the patient and not kind of panicking with it, basically. So
yeah.
managing uncertainty with confidence. Now, this word dilemma is obviously a huge buzzword that we use on the course. It's
Yeah.
something that I think is a game changer for actually all three domains in a
Yeah.
sense. And I suppose that now brings us on to relating to others. What
Yeah.
what do you think the main I suppose what was the power of the word dilemma for you, and why do you think it was so powerful?
Do you know what it was? It was for me. It I had the first time around. I had the same sort of situation. I would get to a point where there was this irritation which appeared, and I realized I was floundering because I
Yeah,
couldn't handle it. It was at 5.5 minutes, and I kept and I kept getting marked down on that. And I think when you highlighted it, actually you made it very clear that that is kind of the point of this
yeah,
exam. It's not about adhering perfectly to nice guidance. It is how can we get round, sticking as closely to nice guidance, but respecting the patient's
yeah,
ICE and the social circumstances. And then the whole point of the dilemma is weighing up the pros and cons and explaining to the patient, yeah, there are some compromises here,
mm,
because yeah, and we may have to compromise some aspect of your care, but actually, if it's allows us to move forward safely, then and in a way that works for you, then really that's the core of it. That's
yeah,
it's the core of it is respecting their rights and
yeah,
their ideas, concerns, and expectations, and
yeah,
that is why the dilemma is so powerful, I
yeah,
think, because it encapsulates one word why that you really do understand what their situation is, and that's to me why I think I was just desperate to for someone to explain it to me,
Yeah.
and then you came along at the perfect time, so thank you.
So I'm glad that the word allows you to vent your frustration,
Yeah.
and hopefully it'll be useful in real life as well, because actually I use it quite a lot in real life,
Mm.
to be
Well,
honest.
actually, and that was actually one thing that I, reflected on quite a lot is in terms of practicing with patients. You talk about real life.
Yeah,
I think again, first time round, when I was practicing with patients, I was really wanting to stick to the 12-minute mark. I was thinking, right, with every patient, I need to be
yeah, yeah,
data gathering the first 6 minute, focusing like it was an SCA
yeah,
exam. And
yeah,
actually, I
yeah.
think I realized second time around that real life isn't like the SCA exam.
No.
Actually, what is much better to be done is focus less on the timings, and less about, diagnosis at 6 minutes, completing it by 12 minutes. It might be a bit longer, might be a bit shorter, but actually use these words dilemma, get used to using it, and also using things like the terminology for shared plans, rather than saying, I think we should do X, Y, Z, getting used to saying, would you be open to
Brilliant.
X, Y, and Z? And actually, when I started doing that in my recordings and looking back on those, and yes, they might have gone to 13, 14 minutes or even 8 minutes, it that allowed me to practice much more
Definitely.
and get much more out of it than just sticking to the timings.
I can't agree more. I mean, it's just so important that actually there are so many opportunities in real life to practice these behaviors, as opposed
Yeah,
to the case. It's actually the behavior
yeah.
that needs to become second nature. Well, I'm so happy for you, Tom. I mean, this is a really, really good outcome for you, and CCT round the corner. What's the plan? You're a young dad. You've got lovely kids.
Mm.
What's gonna be the plan moving forward?
Well, you're right. Day to day, it's survival. With I've got twin baby twins. It's about getting through each day.
Yeah.
Not getting too tired by the 5 a.m. starts. But yeah, so I'm due to join a practice in about a month's time. So
Oh,
it was one of my
fantastic.
training practices. So I've got that lined up. So I'm really really pleased about that.
Oh,
And
brilliant.
they were so kind. They did put the role on ice, while they
Oh,
accommodated
amazing.
this extension. So
Oh,
yeah, and then moving forward, there's lots of ideas, whether special interests and
mm,
things, I've got in my mind, but nothing concrete at the moment. But just hoping to get my feet under the table and just get comfortable as a salaried GP, getting used to again the day to day and
yeah.
the timings and things, because I think there'll be a big increase in the workload, and getting used to that, and then we'll see.
Good,
We'll
excellent.
see
Well,
after that.
exciting times, and you must keep in touch. GP is a very, very small world. So, if anything I can do for you, just
Yeah, I'm sure we'll come across, and
we will
and
definitely.
I've already recommended your course to a lot of people, and I'll continue to do so. So,
That's
thank
very
you
kind of
very
you.
very much, Nigel.
Thanks, Tom. All right, take care.
Thank
Thanks
you.
so much, mate.
Okay,
Take care. Bye.
thank you.